Hello, everyone. It's nice to see some familiar names. We might give just maybe another minute for people to trickle in, and then I'll get started. All right. Well, you're in the right place if you're here to learn about point of care ultrasound and some high yield uses of this tool in urgent care and primary care. Um, my name is Dr. Tatiana Haberlock. I'm an emergency physician and founder of Hello Sono. I've been using POCUS clinically for over 15 years, and that's ranging from emergency departments to urgent care to even Everest Base Camp. And now I'm on the mission of bringing this tool to primary care and urgent care so we can provide more efficient and better care to our patients. And before I move forward, I also want to introduce you to Lana Sanderson. She is helping us run the webinar. So if you have any questions you want to ask anonymously, uh, please just send her a message and she will do a Q&A at the end. And a little bit more about myself. This is actually a picture of me at 17,000 feet at Everest Base Camp doing a renal study on a patient there. And that was the only imaging modality we had. And if we can do it at 17,000 feet on a glacier in a tent, I am certain we can make focus happen in your clinic. These are my awesome two cats, Hunter and Sage. They helped me put together this presentation. And I've been recently pretty obsessed with pickleball, so I'd be happy to either talk focus or play some pickleball with you. And Lana, we have a quick poll for our participants today just to learn who's in the audience, whether you are providers or administrators or maybe both. What space do you practice in? So we have some answers. So it looks like there some emergency medicine providers, urgent care providers, and inpatient medicine providers. And also, we are asking you, are you currently using ultrasound? Are you billing for it? If you are using it, and how many of you are not using it at all? Um, so it looks like 60% are actually using and billing for ultrasound, which is great to hear. Okay, Lana, I think we've got most people voted, and I hope you guys can see your results, the results. Okay, okay, here you go. So we'll scroll through these. So you know who's in the audience. All right. And I'm going to stop sharing and let's stop the poll so we can move on. All right, this is still now. So today's agenda. We are going to cover five different focus applications, and those include lung ultrasound, DVT, soft tissue, musculoskeletal, and bladder ultrasound. I'll go over some of the common indications to perform these exams. We'll discuss some of the techniques and views you'd obtain. So this is pretty clinical heavy here. And then we'll look at what a normal finding would look like and what common pathology might look like on ultrasound. And then finally, we'll also discuss the impact this modality would have on your patient, on the practice, and on the clinician. So let's start off with my favorite, and that's lung ultrasound. The indications for this exam would be patients with shortness of breath, maybe someone with mild CHF exacerbation that you're seeing in outpatient setting, and you're debating whether they need to be going in for diuresis to be admitted, for example, patients with pleuritic chest pain, or maybe infectious symptoms. So we answer very focused questions with POCUS, and those are, is there a pneumothorax? Is there pleural effusion? Is there pulmonary edema? And is there pneumonia? So staying really, really focused. We are not going to find out everything about that patient's lungs. So the technique for this ultrasound is typically you will be using a curvilinear phase array probe. So those are the ones here on the right side. They have higher penetration, so they let you see most of the organ, but a little bit lower resolution than this linear probe. The linear probe you use for superficial scanning. So if you're scanning a child, or if you are just looking at the pleura, you might choose to look with the linear probe. And it's an interesting thing with lung ultrasound is we are actually looking for artifacts. So when the sound beam hits air, it actually gets scattered. So we are not seeing the actual lung if it's air filled and normal. We only see lung when there's pathology in it, like consolidation of fluid. And we are going to look at least six fields, so three on each side. Typically, that's the minimum you want to hit. Obviously, you have high suspicion, you want to be looking in more areas or scanning just down patient's back and the sides and the front of the chest. So those six views, you want to look at the APCs. This view is most sensitive for a pneumothorax. So that's second intercostal space, midclavicular line. And then you're going to look at the posterior axillary line at about fourth intercostal space. That's a more dependent area, so you will see more pneumonias in that area. And then finally, you want to look at the costovertebral angle or the basis of the lung, because that's the most dependent area. So it's the most sensitive for effusions. So this is what a normal lung ultrasound looks like. I'm going to play a little clip. So this top line up here, this is a hyperechoic line, a bright white. That's the pleura. And it is surrounded by two rib shadows on each side. So the rib is this hyperechoic, a bright white line, and then it blocks ultrasound beam. That's why you are seeing um, a shadow there. So the first thing I want to notice is that there's a pleura that's actually shimmering with there's a subtle shimmering there. So that tells me that parietal and visceral pleura are moving against each other and there's no pneumothorax. Sorry, this was looped earlier. Now it's not looping. Another thing I'm noticing here is that there are horizontal parallel lines, and that's one of the artifacts we look for in ultrasound when we are doing long ultrasound. So this actually is a reverberation artifact, and those lines are called A lines, and they are only present when the lung is air-filled. I'm not going to go into details of how this artifact gets formed, but basically you're looking for these horizontal lines and the shimmering pleura, right? So the pleural sliding and A lines, and that tells me that the lung is air-filled and then there's no pneumothorax. And basically, these are the views you're going to get. And we're demonstrating on the right side. You will do the same thing on the left side. So you're looking at that long apex with your probe marker towards patient's head as a sagittal view. And this is a type of image you might obtain. Once again, you're looking at that pleural sliding and A lines, right? So the pleural sliding right there, slight shimmering, and the A line, the horizontal lines. We next move on to that axillary view, and this is with the patient being supine. And this is coronal section that you're getting of the lung. And this is that view that I've already shown you. Once again, we're looking for A lines and pleural sliding. So pretty simple so far. Once you get to the base of the lung, you're still in that coronal plane. You just slide that probe downward from the axillary view. And now we are seeing the liver on the right side, part of the kidney, and this is actually the diaphragm. So the probe, the way the probe is oriented, because the probe marker is pointing towards patient's head, we are getting the thorax is here. So on the left side of the screen. And here, once again, because the lung is air filled, we don't get to see the actual lung. Instead, we see what's called a mirror image artifact. The liver is reflecting over the diaphragm. The same thing happens with the spleen. The spleen will reflect over the diaphragm. Another thing I'd like you to notice on this specific view is that this is And I would normally make it super interactive, but we don't have a ton of time. So this is actually spine. The hyperechoic area, that's spine. It's highly dense. That's why you're seeing it hyperechoic or white. Um, so the spine is ending at the diaphragm. Because there's air and we're not able to see the spine continuing into the thorax. We know it's there, but we don't see it. So this is normal, and that's called no spine sign. If we were to see the spine continue into the thorax, that would be abnormal, and that's called spine sign. So in this view of the basis, we are looking for that mirror image artifact and no spine sign. So what would a pneumothorax look like on ultrasound? So here's a little clip. We are using a linear probe. These are the rib shadows on the sides, and this is our pleura right here. And although we are seeing some motion, it's actually motion of the soft tissue and the muscle rather than the subtle shimmering of the pleura. So this is a pneumothorax. And for comparison, I have that there's no pleural sliding. Once again, showing you the shimmering, the subtle shimmering over here of the pleura. There's another very cool sign I would love to show you related to pneumothorax. So watch this clip real quick. So do you see how on the left side, the pleura is moving in and out, and this right side is really not moving? So this is the exact point where the parietal and visceral pleura is separated. That's called a long point, and it corresponds to this area on the CAT scan. And basically, a long point is pathognomonic, so 100% specific for pneumothorax. So basically, if you find long point, you ruled in a pneumothorax. But another cool thing about long point is depending where you find it on the body, if it's really far high to close to the apex, that means it's a very small pneumothorax. While if it's further down the thorax, it's sort of more inferior, that tells you it's quite a big pneumothorax and you should be expediting care for that patient. The pulmonary edema. So remember those A lines that we are supposed to see? Well, guess what? These A lines now become B lines, very simple. But the B lines are these vertical lines that we are seeing that are emanating from the pleural line down the screen. So we are seeing some confluent B lines here. The more you have them, the more fluid there is in the interstitium. And these B lines can be focal or diffuse. So focal B lines could be something like a early pneumonia, or you can have scarring in the lung that can give you focal B lines. Versus if you see diffuse B lines, those are more consistent with either CHF or maybe ERDS if the patient is in ICU. And the cool thing with B lines, you can track progress. So if you diurese the patient, the B lines will disappear pretty quickly. And here's an example of a pleural effusion. So remember that mirror image artifact and the lack of spine sign. Here we're seeing the opposite, right? So we're seeing this liver and it's not reflecting over the diaphragm. Instead, we're seeing black anechoic fluid here, and the lung is actually pushed down by the fluid. So this is the lung right here. This clip is not wanting to play, so hold on, let me try it. And then notice in the spine, right? Instead of ending at the diaphragm, it's continuing into the thorax, right? It's because there's fluid that's conducting the sound beam now. So we are able to visualize the fluid. So this is what an effusion looks like on ultrasound. So we're seeing that spine sign. And finally, what would pneumonia look like? There are different types of presentations from pneumonia. So focal B lines, we already discussed. That could be a sign of early pneumonia, but this is what a more developed pneumonia at the right base of the lung looks like. So once again, we are seeing that spine sign right here, a little bit of pleural fluid, but this is the consolidated lung that starts looking like the liver. And if you look very closely, there are these white little specks of worms that are moving in and out with respiration over here. So those are actually air fluid levels. So it's trapped air fluid levels, air and fluid inside the bronchioles, and these are called dynamic air bronchograms, and they've been found to be pathognomonic for pneumonia. If you see this, basically that's 100% pneumonia. Versus it's very helpful when you have a chest X-ray read that says atelectasis versus pneumonia clinically correlate. Well, ultrasound can actually tell atelectasis versus pneumonia apart. All right. I know this has been a lot if you haven't done a ton of ultrasound in the past, but I do want to also um, talk a little bit about the impact of ultrasound. First of all, you are avoiding radiation. That's super important in pediatric and younger patients. If you are suffering from X-ray tech shortages in your practice, this is a way to um, basically, at this point, if you don't have an X-ray available, you have ultrasound as another modality that often is more sensitive for a lot of pathology we see in outpatient setting, more sensitive than X-ray. You get to rule out dangerous pathology at the bedside, including a pneumothorax. Obviously, you're saving time and cost for the patient, and you also get to start appropriate treatment sooner. And another cool thing with ultrasound, the patients get to see what's going on, whether it's a pneumonia, but you can show that to them at the bedside. So there's an opportunity to educate your patient. And that brings us to our next quick poll. And I am curious, Lana, whether you could help us bring up the poll on X-ray staffing. Are any of you experiencing X-ray staffing shortages? I know this is an issue in urgent care space, um, and it seems like we have a 50-50 split. Oh, someone got 100% staffed. Congrats. So it seems like most of you are experiencing some kind of extra staffing shortages. And I think we can stop the poll at this point, Lana. Thank you. Uh, so having an opportunity to do a lung ultrasound when you are would have otherwise ordered a chest X-ray, that's really a huge plus for your patients. Moving on to lower extremity DVT ultrasound. Once again, the indications for that would be obviously patients with unilateral leg swelling, leg pain, or maybe someone who has history of PE or you're concerned for PE. But basically, we are looking for a clot in the lower extremity in the deep vasculature. So for that, you would most use linear probe. Linear probe is high frequency probe that gives you basically better resolution, but lower penetration. Sometimes we use a curved probe for patients with bigger body habitus. And we are basically doing compression technique. We are compressing the vessels from the inguinal region, common femoral vein, to below the popliteal vein. And basically, if you're able to compress the vein pretty easily, completely, there's no clot. There's very good evidence for this technique. And we are only evaluating for proximal leg DVT with this technique. So we are not scanning all of the calf. Just review of anatomy. So veins are going to be, hold on, medial to the arteries. I always have to think of navel. And we are going to start in the inguinal region. There are three things we need to look at in the inguinal region: that common femoral vein, that's two circles that you're going to see on your screen. Then there's the saphenofemoral junction, where a great saphenous vein comes in and joins the common femoral vein. You've got a confluence of deep and femoral vein. It's all in the same region, so that's one region that you're looking at. Then you're going to also look at the isolated femoral vein in the mid-thigh, and then also behind the knee at the popliteal vein. And this just shows you the position of femoral vein and arteries related to each other. So this is actually a three-point compression technique. And the sensitivity for a clot is over 96%, 97, depending what you're reading. So it's on par with the vascular Dopplers that you would get normally. So this is what I just wanted to demonstrate what a compression would look like. So artery doesn't compress, but the vein does, and you're literally just pushing down to make sure the walls touch the inner walls. I'm going to go through these quickly. I know we don't have a ton of time, but this is what a compression of SFJ, saphenofemoral junction, looks like. This is a compression of the deep femoral vein and the femoral vein. Oh, my computer is being slow. Here we go. The arteries don't compress, but the veins completely collapse. So that's what we want to see to verify that there's no clot. This is our femoral vein being compressed. The artery is not being compressed. And this is the, ooh, missed this. And this is our popliteal vein that sits on top of the artery, superficial to the artery, that is being compressed. So just to review real quickly, these are the five kind of views you want to get: the common femoral veins, SFJ, um, deep femoral vein and the confluence of the deep femoral vein and superficial femoral vein, and then isolated femoral vein, popliteal vein. For me, this takes under 2 minutes to perform. It is actually quite a quick exam. You're literally dragging your probe down the leg and compressing. And left lower extremity would be the mirror image of this. So this is a few slides of pathology. So this is left lower extremity common femoral vein DVT. So the vein is actually here, it's dilated, and there's a clot. Although you can't see the clot very well, this person is pressing pretty hard and they cannot compress this vein. So we assume that there's a clot there, and that's a positive scan. This is another one that also has a color flow at the same time. But even with a color flow, you're seeing no flow in this vein. That's a femoral vein with a femoral artery on top. And when you try to compress it, it's still not compressible right here. You can see that. So that's a left lower extremity DVT again. So the impact, I think this one is a huge one, right? So it's saving time and cost for the patient. You get to start the correct treatment way sooner. And that's a great reassurance tool because most of the time these scans are negative, right? So probably 85, 90, maybe even 95% of them are negative. And it's such a great way to reassure your patient and not have them go and wait around in the ER as well. And of course, the ones that you do end up sending to the ER or sending for imaging, imagine those people, perhaps they are not going to follow up, or there are some barriers to getting ultrasound done. Of course, by catching this early, you're starting patients on a correct treatment and hopefully avoiding devastating outcomes. I did want to share, we do have a simple clinical pathway that incorporates well score for risk stratification, and then D-dimer and POCUS in outpatient settings. So feel free to grab it. We'll also share a link and in a follow-up email as well, so you can download it. Moving on to soft tissue and MSK ultrasound. So those indications would be focal erythema, edema, pain, maybe some bony injury, deformity, foreign body, especially if it's radio opaque, and also for procedural guidance. But basically, the focused questions you're answering with POCUS is there cellulitis or an abscess? Is there a fracture, dislocation, a tendon injury? Is there a joint effusion? Is there a foreign body? So tons of great applications for this technique. For the most part, you're going to be using high frequency linear probe, and you want to look at structures at least two planes. You can use color mode to identify vasculature that's surrounding or rule out a vessel, for example, if you're seeing something that looks like an abscess, but you want to make sure it's not a vessel. And just always make sure to scan the contralateral side for comparison. It can be really, really helpful. So these are some skin tissues. This is what a normal soft tissue ultrasound looks like, right? So this is epidermis, dermis, very thin lined subcutaneous tissue. Fascia looks hyperechoic, right? So, and then there's muscle with citrate striations in a longitudinal view here, and now the fascial plane and muscle again, and this is like bone here. So for soft tissue infection, pretty obvious, right? So this is the normal that we just looked at, and this is the abnormal side. So here we are seeing either edema or cellulitis, but one thing to look for is cobblestoning. So you see this adipose tissue being surrounded by anechoic fluid. You're having increased thickness of the subcutaneous tissue. So here our subcutaneous layer excuse me, ended right here at the depth of half a millimeter, right? This is 2.5 centimeters total. Well, here, our subcutaneous tissue is ending at 2 centimeters, so it's a lot thicker. And then you can also look at echogenicity. So in this case, it looks relatively hyperechoic in comparison to the other side. So this is a little clip of the cellulitis or edema um, of the leg. So we're seeing a lot of cobblestoning. This is an example of a pretty large abscess with some cobblestoning around. So there's some element of cellulitis here, and that's on the patient's back. But really helpful to also see the size of the abscess, how deep it is. So this is 2.5 centimeters deep, the total depth of this clip. And then finally, another application for soft tissue is the foreign body. So this one on the left is actually a wooden splinter that's blocking ultrasound beams. So that's why you're getting the black shadow. This is something you would not be able to see with an X-ray, but you can see very clearly with ultrasound. And this is actually a metal paperclip that we are seeing with ultrasound. So it also picks up metal very well. Moving now to joint effusions. So if you wanted to look at a knee effusion, we're using linear probe. We are in the sagittal plane. We are placing it over patella, and we are trying to capture that quadricep tendon. This is a potential space where fluid can collect in the suprapatellar recess. And then we got the femur. So the correlating these, this is your patella right here with a deep shadow because it's blocking ultrasound beam. This is the femur. And this is your quadricep tendon. And all of this is adipose tissue with no fluid collection because fluid appears black on ultrasound. Um, we do have an abnormal one over here, right, with the fluid collection, and this is your quadricep tendon. Fractures, this is actually my partner's fracture, rib fracture, an accident while skiing. Uh, Quite obvious, right? So if you have disruption of the cortex and you can verify it in both planes, you literally put the probe at the maximal tenderness to see this. But it's also been shown for specifically for rib fractures, ultrasound is better than X-ray. It has 97% sensitivity and 94% specificity. And the cool thing with ultrasound, you get to rule out, a pneumothorax in this case. So, and then finally for MSK, a final application that we'll cover is tendon evaluation. So this is a kind of hard to see pixelated um, quadricep tendon. Oh, sorry, not quadricep, Achilles tendon, and it's attaching to the calcaneus, that bright white or hyperechoic area. That's calcaneus bone, and this is the attachment area. And you'll see these striations that are horizontal. That's the Achilles tendon. But look at this. This is complete rupture of Achilles tendon with fluid and probably some blood and inflammatory fluid that we are seeing. You can very accurately also see a partial tear of Achilles tendon, or honestly, any tendon. I'm just showing you the biggest one because that's also the easiest one to learn. So, in terms of the impact, we avoided radiation, we saved time and cost for the patient. You're increasing safety of your procedures if you are doing procedures because A, you're verifying is there a good fluid pocket to drain or aspirate. You're also localizing your foreign body before trying to remove it and verifying there's no vasculature in the way. And of course, you're improving the diagnostic accuracy, so just easier and better to make a clinical decision. All right, and our final application is bladder ultrasound. I have no idea how I'm going on time here. Okay, we gotta wrap it up, but really the indication here is urinary retention, no difficulty urinating, suprapubic pain. You are wanting to know post-void residual. You're gonna use your curved probe, get two views, measure width, depth, and height. So this is me performing a transverse view of the bladder, and then I'm gonna get the sagittal view of the bladder. And then you get to measure them. So width, depth, height. So because of the shape of the bladder, you do want to multiply it by a corrective coefficient. And that ranges from zero point 0.5 to 7. I'm putting zero point 0.5 so we don't overestimate our volume. This is a very distended bladder. And the impact is really we are once again improving diagnostic accuracy. We are putting urinary catheters when they are really indicated, and we are saving times and costs for the patients. There are a ton of other common use cases for patients in primary care and urgent care, including cardiac ultrasound to look at EF or pericardial effusions, flank pain to look for hydronephrosis, screening for AAA, for example, a right upper quadrant ultrasound, and of course, procedural guidance for IV insertions or joint aspirations. And one more, one of my favorites is ocular ultrasound for ocular complaints. So you can rule out vitreous hemorrhage, retinal detachment, foreign bodies. All right, I am going to run through this slide because I know we are up and I want to get to Q&A if any of you want to stay and have a little Q&A. But this slide is all about really the positive impact that ultrasound has on the patients, the provider, and the practice. Um, these are patient experience slides. There have been great studies from primary care and inpatient medicine showing that patients feel like their quality of care is improved, the level of service is elevated when they get POCUS. There's such a thing as POCUS positive care effect. Um, so I think we're going to skip our last poll. And uh, the key takeaways is that lung ultrasound is really highly sensitive. A lot of pathologies uh, in the lung. Uh, Compression technique is really adequate and quick to do and safe to do to rule out DVT in the outpatient setting. And also, a big takeaway maybe for some of you is that POCUS detects those radio opaque foreign bodies that X-ray might not detect. Our next webinar is on April 7th, and it's on POCUS credentialing standards and how to develop confidence in POCUS. We'll share that in the links. This is all of our links in here, including resources on DVT, pathway, and CPT codes. And now, thank you so much for staying with me here. And I'll take a few questions if there are any.